Hi, my name is Sian Thomas and I'm a lead paediatric occupational therapist at Neath Talbot Children's Centre, which is part of Swansea Bay University Health Board in South Wales. Our service is a small provision, core team of occupational therapists who see children and young people with a range of paediatric conditions in the community. In this 10-minute presentation, I will be given an overview of the work we are undertaking currently to support children who have a clinical presentation of ARFID, and our hopes in developing a service for this population of young people. The presentation will conclude with a story developed with a parent of a child with ARFID, the impact of the condition on family life, and the therapeutic intervention we delivered in collaboration with our multidisciplinary colleagues. For those unfamiliar with the term ARFID, clinical presentation includes the intake of insufficient quantity or variety of food to meet adequate energy or nutritional requirements that has resulted in significant weight loss, clinically significant nutritional deficiency, dependence on oral supplementation or tube feeding, or has otherwise affected the physical health of the individual. For ARFID to be considered, significant impairment of personal, family, social, educational, occupational, or other important areas of functioning must also be present, for example, due to avoidance or distress related to participating in social experiences involving eating. What we know about ARFID. Avoidant Restrictive Food Intake Disorder, or ARFID, is not a new disorder, and the term was introduced under the DSM-5 criteria, replacing previous terms such as selective eating disorder. Despite being 7 years on from identification in the DSM-5, in clinical practice there is very little awareness of ARFID, and as a result the condition is often overlooked or misdiagnosed. In this group of patients, it is common to hear high levels of anxiety reported from families in search of appropriate care, which meets the complex needs of this population, and at present there is no formal service provision in Wales for ARFID. At a recent conference I attended on the condition, which brought together teams and services working with children and young people with eating difficulties across Wales, services reflected on a scattergun approach to referrals and those with an ARFID type presentation, with all services having a percentage of such referrals but with no clear guidelines on identification, assessment tools and how intervention should be delivered to this service group. The gaps. It is clear then there are gaps in services which are frequently reported in clinical articles and literature regarding the condition. Whilst there are pockets of good practice, it is often down to the knowledge and interest of the individual clinicians, and families often report confusion over conflicting advice given via the variety of services they seek advice from. This can lead to the family seeking private consultation in other parts of the country, which can bring its own challenges. The impact of the lack of early identification in this group often puts undue pressure on families and puts the young person at a higher risk of developing secondary conditions such as mental health disorders. Recommendations from experts in the field. The good news is that the condition awareness is growing in the public arena and in clinical practice, and in our experience, liaison and training from Dr. Rachel Bryant-Wharf, a clinical lead in ARFID based at the Maudsley Centre for Children and Adolescent Eating Disorders, to services across Wales, has been pivotal in developing professional confidence and providing clinical evidence and structure to assessment and intervention. Dr. Bryant-Wharf was involved in developing the DSM-5 criteria for the condition and has developed assessment tools to support clinical identification, which she has kindly shared with our local colleagues. Amongst other aspects, one of her key recommendations is that collaborative, multidisciplinary approaches to identification and treatment of ARFID are necessary to achieve successful outcomes for young people and their families. As a local health board in Swansea Bay University, it is our vision for patients and families with suspected ARFID to have access to a robust multidisciplinary assessment involving dietetics, CAM services, occupational therapy and access to psychology, family integrated therapy consultation. Intervention should be collaborative and delivered by therapists with clinical training in ARFID and sensory integration, using the best practice tools and assessments developed, as discussed in the previous slide. An accredited training course for professionals is in development at the University of Winchester, and it is our hope that all clinicians working in ARFID have access to such modules. At present, we are working across 3 services located in 2 different health boards to access individual professionals with the relevant training and knowledge of ARFID, and are informally delivering a pilot of intervention to these identified as suitable. We are in the process of developing an integrated pathway across services to formalise and further gain clinical evidence via formal pilot study with a view to commissioning a service for ARFID patients. The following parent story gives an example of how collaborative working can support positive outcomes for families. Thank you for listening.
Obviously, Kieran, from even the age of 2, when he started eating solids, he never liked solids, didn't take to them at all. We've been back before the doctors, I would say, for the last 10 years with Kieran regarding his food. They kept telling me he'd grow out of it and not to worry. It was affecting him with his sleeping, his mood, everything. As a family, it took over our lives. We couldn't go out for food. When we went on holidays, Kieran never ate. It was stopping us from even socialising as a family. And our other son then, he wanted to go for pizzas for his birthday and we couldn't go because Kieran just refused to go to these restaurants. And in at least 4 years, Kieran only ever put on about £2. My doctor, to be fair, has put us forward to CAMS twice and he's been rejected. We did get an appointment with occupational therapy when he was younger, and they told me that Kieran had big sensory issues. I went back to my GP again last year in January and said, I'm not happy with Kieran's weight. Everybody was telling me he was looking unwell, he was looking ill, he wasn't eating, he had no appetite, he had no energy. He became quite depressed, quite isolated, and just, it wasn't nice to see. And what's heartbreaking for us as a family is to see your son sit on his bed many nights crying, saying, why am I like this? Why can't I eat food? Why won't people help me? That's quite upsetting for us because I just feel that we didn't get the help we deserved and we should have had. And then in the summer, when Kieran was in school, he was bullied in school then. And then Kieran just decided to stop eating altogether. So I contacted the school, Kieran's head of year, and she put me through to the school nurse, who then came out and did an assessment on Kieran. They said then they would get Kieran referred to CAMS. Sian and Kim came out of the house and got him with his hands into foods and textures and tastes and smells, something that Kieran's never done before, because whenever we've asked him if he'd like to cook with us, he's point blank no, because he's so afraid of foods and so afraid of everything regarding food. They got him touching bananas, things he would never have done before. And then you could see he started to enjoy cooking and started to enjoy the fact that food wasn't a bad thing, it's something that's going to make him stronger and get him to where he should be. So they were here every week with him, and I have to say, without the 3 departments coming together, we would never have had the outcome we've had, because Kieran's gone from 5 stone 4, he's now 6 stone 10, and he's done that in less than 6 months, where we fought with the doctor for 4 years and he only ever put no more than £2 on. 6 months ago, I'd sit there and say, well, you have to eat that food and you've got to do it. And then he would be screaming at each other, he'd be crying, I'd be crying. I wouldn't sleep in because I was so worried about, oh God, imagine he does go down the anorexia road. It was so stressful. And, we are a lot calmer as a family now because the professionals have come in and said to us, it's okay to do it this way, and it's okay if Kieran doesn't want to try new foods. It's all about just sustaining his weight, making Kieran comfortable around food. These 3 teams together was an overall view on everything that we needed to know going forward. So, I think it's been absolutely amazing. And, I hope that in future, They can get funding to help children like Kieran.
And I presume you don't like sweets very much, is that right, Kieran?
Oh no, I love sweets.
He loves sweets and crisps and chocolate.